Yes, sir. Yeah, just 1 second.
One Professor Sarla from my earlier institute, who is the chief of pharmacology, and then probably Dr. Gitanjali also might be knowing her. Dr. Sarla from Kolar. I think she had brought you to sometime almost a year, 5 years back.
Yes, I know her, sir. Yes.
Oh, yeah. Incidentally, she's here.
Okay, that's nice.
Good afternoon, sir, and good afternoon, Gitanjali, ma'am.
Good afternoon. Good afternoon, Dr.
Good afternoon, ma'am.
I don't see your video. Hello, Sarla.
Okay. Good afternoon, friends. This is a Friday afternoon, and we are back with our Forefront of Future Frontiers, the medical webinar series. And for the benefit of participants, we'd like to say that we started in the month of May, and we have been exploring different themes on each series. So currently we are in the series 8, and the theme for series 8 is on emerging and re-emerging infections. And today we have episode number 38. That is what Dr. Kathleen is going to speak. And she is going to, today we have a very interesting talk. We have with us Dr. Catherine Holloway. She is going to talk to us about how to contain antimicrobial resistance and promote rational use of antibiotics, especially in the COVID-19 world. So that is the talk for us today. And before we start, I would request our Dean, Dr. Kotur, to welcome the speaker. Over to you, sir.
Yeah. Good afternoon to all the participants. My special welcome to Dr. Kathleen, Gitanjali, and Professor Bhatt, and my other colleagues, Mahalakshmi, and Medical Superintendent, and all the participants. Yes, we are in the, this is 37th episode. And, just Professor Gitanjali has already shared the platform on this. And just for the information of Dr. Kathleen, the platform has been shared by eminent scholars, academicians, scientists, educationists all across the globe from all the continents. They have shared the platform. And this we started in the time of COVID when we were all confined to these four walls and feeling claustrophobic and nauseating. That time we humbly started this program and to cater to the needs of our all medical fraternity. Then in no time we earned a credibility as is evident by about our the data, which is nearing 10,000 people now. Many a times, our attendance has been gone up to even 700 to 900 for each of the episode. That's and on behalf of our management, on behalf of our university, on behalf of our Honorable Chancellor, indeed I'm privileged to welcome Dr. Kathleen from Sussex, UK, to be amongst us, for sparing her precious time for this wonderful noble cause. One or two thoughts on this today's topic. Already Mahalakshmi said that it's very important one. Antimicrobial resistance has been an important one ever since, of course, WHO also identified as one of the important 10 public health threats facing the humanity. And this gained more significance when we were stuck with the COVID COVID pandemic across the globe, wherein we were all disturbed, destroyed, or all kinds of things happened. And it got an increased significance, we all know, because, there being no clear-cut any guide marker or anything, whether a viral infection or bacterial infection, especially in our countries, the developing countries, the usage of antibiotic has multiplied and has increased. And one of the main reasons for antimicrobial resistance is overuse or superuse of these antibiotics. And at the same time, some good thing also happens that your use of the antibiotic will cause the spread of the microbials across. So that also, in a way, it's a bifold activity, one opposing each other. This is where we stand. I was just now informing our esteemed speaker that in India we're all scot-free, living almost a near normal life. Normal life, what is was before, that kind of a thing. Of course, there is a fear always in the back of the mind of each and every citizen, even the administrators, even the politicians, even the leaders, that by looking at the papers, what is happening across the globe and all, whether some that African strain is coming or UK strain is coming, these kind of things are also haunting our minds. But anyway, one good thing that has happened is, good population of India is using these masks, this hand sanitation. That's why I say that it is a kind of a blessing in disguise what COVID has given. Because the level of personal hygiene and all, we are not say bad. We never used to give much importance for that. Now everybody, however illiterate or illiterate he is, has been following these norms. That is the gift the COVID, the pandemic has given to our country. I can see this way because there is no alternative. With these some thoughts which are coming randomly to my mind, I once again welcome Dr. Kathleen to share her experiences. Thank you, one and all again. Over to you, Mahalakshmi.
Thank you, sir. Let me introduce the speaker to the audience. Right. Okay. This is Dr. Catherine Holloway for you. She's an honorary associate in the Institute of Development Studies, Sussex University, UK. She was the former medical officer in charge of essential medicines at WHO Geneva and also the regional advisor for essential medicines in CRO, that is Southeast Asia Regional Office of WHO. That's where I think she worked with our Gitanjali madam, and that is how we got to know Dr. Kathleen. Thank you, Dr. Gitanjali, for providing the context. I think this time also, when I marked the mail to you, you actually helped us to get in touch with Dr. Kathleen is actually a public health specialist. She is specialized in the public health use of pharmaceuticals. She has got training in both hospital medicine and general practice in UK. That is, she worked in NHS for 11 years. And she's got the unique distinction of being a member of both the Royal College of Physicians as well as the Royal College of General Practitioners. And she has got a master's in public health and a PhD on impact of user fees on prescribing quality in Nepal. She has worked in a show with a lot of NGOs, and that is when I think she has worked in Myanmar, India, and all with TB, leprosy, malaria, all those things before she moved into essential medicines. And her main specialization is in the management of pharmaceuticals in the middle and low income countries, especially with regard to what are the trends in the use of medicines, what is the impact of health system strategies, policies, and infrastructure on the quality of medicines, and how we use the antibiotics, how to develop an integrated health system approach. It needs to be both practical and affordable, given that the focus is on middle and low income countries, and how we can improve the management of medications at country level. I think this is a tall order for anybody to follow or do. So this is what Dr. Kathleen has been doing, I think, in her entire service with the WHO as well as in the CRO office. And she is going to share some of the how to contain antimicrobial resistance and how to promote the rational use of drugs and especially antimicrobials. And with the current slant of how in the COVID situation. So this is going to be the talk, and I'm really looking forward to Madam sharing her experiences with regard to how she has planned the WHO medications and essential medicines. So over to you, Dr. Kathleen. And before we move, I would like to the participants that this session is being recorded for posterior use for academic purposes. And also we are going live in YouTube. So you can see the symbol on the right upper quadrant of your screen. It just says live. So that is YouTube live. And all the recordings are available in our FFF channel. So you can watch them also. So with these announcements, I would like to hand over the stage to Dr. Kathleen. It's yours, ma'am. Stage is yours.
Thank you very much. I would like to thank you and all the hosts for inviting me here today to talk to you about containing antimicrobial resistance and promoting rational use of antimicrobials in the COVID-19 world. Could you share my slides?
Yes, ma'am. Just give me a minute. Just 1 minute, ma'am. Yeah. The slides are on, ma'am.
Okay, so next slide, please. So I'd like to start by comparing two pandemics, COVID-19 and antimicrobial resistance. And COVID-19 has been very visible, but antimicrobial resistance is largely invisible. COVID-19 has had a fast global spread, whereas antimicrobial resistance has a slow global spread. But otherwise, they're very, very similar. They're two pandemics. They're spread by infectious disease. They're everywhere in the world. They involve both zoonotic and human disease transmission. They are affected by lack of access to diagnostics and vaccines. Spread, although now we have got a vaccine to COVID-19, but how much of the population is going to receive that vaccine is another issue. It's spread by global travel and trade. It can be prevented by infection control, hygiene, social distancing, and prudent use of antibiotics. The spread is facilitated by poor health infrastructure, and containment requires global collaboration, transparency, and solidarity. So there's a lot of similarities there. Next slide, please. Next slide.
Slides are not moving.
Yeah, well, it has moved now. Thank you. So WHO has a global action plan on antimicrobial resistance, which was endorsed at the World Health Assembly in 2015, and again at the UN General Assembly in 2016, and it aims to ensure prevention and treatment of infectious diseases with safe and effective medicines. And WHO has been supporting countries to develop national action plans. And there are 5 strategic objectives: to improve awareness and understanding of antimicrobial resistance, to strengthen surveillance and research, to reduce the incidence of infection, to optimize the use of antimicrobial medicines, and that's what I'm going to be talking about mostly today, and to ensure sustainable investment in countering antimicrobial resistance, as currently there are few new antibiotics being developed in the pharmaceutical pipeline. Next slide, please. So first question, I was asked to introduce some questions for people to poll. How many people, and so I thought we'd have an update on safe water and sanitation. How many people globally do not have basic sanitation facilities? How many people globally use drinking water contaminated with feces? And what proportion of health facilities globally lack water and soap for hand washing? I haven't seen anybody answering this in the chat, but maybe by the time we get to questions 2, 3, and 4, there'll be more polling going on. But anyway, if we go on to the next slide, I will show you.
The question answers can be put in the chat box.
So this comes from WHO fact sheets 2019. Unsafe water and poor sanitation is estimated to cause 827,000 deaths annually at least. And 2 billion people in the world do not have basic sanitation facilities, toilets or latrines. 10% of the world's population consumes food irrigated by wastewater, much of it discharged untreated into rivers and lakes. There, of course, is a link to waterborne diseases, cholera, diarrhea, etc., listed there. And it's been estimated for every $1 invested in safe sanitation, there would be a $5.5 saving in lower health costs. With regard to safe water, it's estimated that 2 billion people use a drinking water source contaminated with feces, and WHO, ever since 1958, has been producing guidelines for safe drinking water, which includes 43 microbiological parameters, and unfortunately we're still not following these guidelines. And then in health facilities, it's estimated that 26% of health facilities lack safe drinking water, 21% adequate sanitation, and 43% lack water and soap for hand washing. So this was from the WASH report in 2019. So that's a little update on where we need to go for good sanitation and hygiene, which would affect antimicrobial resistance and COVID. Next slide, please. Next slide. Thank you. So antimicrobial stewardship is needed to contain antimicrobial resistance, and this has been defined as a coherent set of actions which promote using antimicrobials responsibly. So I'm only going to be talking about stewardship. I'm not really going to talk anything more about infection control, sanitation and hygiene. And this is the ESCMID study group definition, and it balances the individual need for appropriate treatment and the longer term societal need for sustained access to effective therapy. It's inherently context specific, varying with who is doing what, and it's applicable from individual level to national and global levels and across humans, animals and the environment. And it requires that we measure antibiotic use as well as quality, access and availability, and investigate why antibiotics are misused in order to identify effective interventions and policies. And we also need to implement these policies and monitor their implementation. And we also need stewardship for COVID-19 with regard to appropriate use, access and qualities, with regard to the use of medicines, disinfectants, personal protective equipment, track and trace with quarantine, and also vaccination. Next slide, please. So WHO has classified antibiotics into the AWARE classification, that is access, watch and reserve. And now all the medicines on the essential drug list are classified by this. So access antibiotics would be those first and second line antibiotics for common infections, which should be available in all countries and all facilities. And it would include things like amoxicillin plus or minus clavulanic acid, benzyl penicillin, doxycycline, gentamicin, and so on, many of the older antibiotics. And they recommend that 60% of national antibiotic consumption should be from this group. And then watch antibiotics would have a higher resistance potential and should be prescribed only for specific conditions. And it would include things like cefixime, ceftriaxone, ciprofloxacin, azithromycin, vancomycin, meropenem. And then reserve antibiotics are those last resort options for the treatment of suspected or confirmed multi-drug resistant infections, and would include things like polymyxin B, colistin, fosfomycin, linezolid. And it's watch and reserve antibiotics that should be particularly targeted by antibiotic stewardship programs. So next slide, please. So question 2 is, what proportion of countries do you think achieve WHO's target of 60% of antimicrobial consumption belonging to the access category? And do you think that the proportion of countries achieving this target on access antimicrobial consumption increased or decreased during 2000 to 2015? And nobody seems to be answering
Zero.
my questions. 0. Okay, well, that's a pretty good answer. There is actually a recent article in Lancet Infectious Diseases, January 2021, where they used IMS data from the pharmaceutical industry to estimate this. And they found that in 2015, from 76 countries, 60%, only 55% of countries, about half of them, achieved this target. And that included high-income countries as well as low-income countries. And actually, this was higher in 2000. 76% of countries achieved this target in 2000, so it's not getting better. Now, this will mostly be, so we've got a lot of work to do. Now, this is a, can you go back one slide? I think we've skipped a slide. Yeah. This data shows, no, we want to go to the next one now. We've dealt with that. So this is community antibiotic consumption in the European Union. And this is complete data. And they've been collecting it over many years, and it's measured, this is measured in defined daily doses per 1,000 inhabitants per day. And no, please go back to the community one, which is the previous slide. And you can see that on the y-axis, there are all the countries listed. And you can see that Netherlands is consuming about 1/3 as much as Cyprus, which is the highest consumer. And the question is, why is it in community consumption, when the case mix is very similar, one country is consuming 1/3 the amount of antibiotic as another country? And of course, there's a lot of antibiotic misuse, and there hasn't been an overall change between the years 2013 to 17 in Europe, although there were significant decreases in Scandinavia, UK, Germany, Italy. Next slide, please. Now, this is hospital antibiotic consumption, and once again, you can see Netherlands is the lowest consumer, and this time Malta and UK are the highest consumers. But if you notice, this is again defined daily dose per 1,000 inhabitants per day, and you'll see the scale here is different. So actually what we see here from Europe is that 90% of antibiotic consumption happens in the community, because instead of 3 defined daily doses per 1,000 inhabitants per day on the x-axis, we would have had 30 for community consumption. So I put this in to show that really we have to concentrate on the community if we are really going to change antimicrobial resistance, because most antibiotic consumption goes on in there. The other thing to say about hospital antibiotic consumption is you cannot make the same judgments between benchmarking of countries, because the case mix in hospitals is quite different in different countries. It depends on your policies of who is going to be an inpatient or not. So next slide, please. Now, if we look at hospital consumption data, as I've just shown you, will tell you the total amount consumed, but it doesn't actually tell you about the quality of use and what are the problems. So here is a study on global hospital inpatient point prevalence. That survey was done in 2017, and you can find this online. 100,000 patients from more than 6,000 wards in 351 hospitals in 51 countries. Sorry, can we go back to that previous slide? And the most prescribed antibiotics were ceftriaxone, coamoxiclav, piperacillin, and so on. But if we look at treatment quality, we see that the reason for prescription was recorded in the notes in 72% of cases. There was a stop review date recorded in the notes in 34% of cases. Treatment according to guidelines, treatment was done with no guidelines available in 23% of cases. Treatment was according to guidelines in 74% of cases. Patients receiving prolonged antibiotic surgical prophylaxis occurred in 69% of cases. Patients receiving targeted systemic antibiotic treatment only was only in 22% of cases, and receiving treatment for multi-drug resistant infections was 17 to 16% of cases. So here we see from a global perspective that there's a lot of improvement to be done in hospital use of antibiotics. Thank you. Next slide, please.
Trends in antimicrobial use.
Yeah, trends in antimicrobial use over time. Now, this data comes from the WHO database on drug use in low and middle income countries. And here we've got some, and of course, it's very difficult to get consumption data in the community in low and middle income countries. So this is looking at standard indicators of drug use in health facilities. And we've got 3 indicators here of antibiotic use. And this comes from published surveys that we have collected from a systematic review. And if we've got on the x-axis here the time, 1990 to 2014, and we can see that in the red, the percentage of patients giving antibiotics in primary care remained at about 50% during this time period. The percentage of acute diarrhea cases given antibiotics was anything between 30 to 50%, didn't really change significantly. But we see that the percentage of cases of upper respiratory tract infection cases given antibiotics has slowly risen from below 30% to nearly 70%. And each of these N numbers refers to the number of studies contributing to each data point on the slide. Next slide, please. And if we look at the same indicators by region, we will see that in the Western Pacific, the Southeast Asian region, Eastern Mediterranean region, we have 60 to 70% of acute upper respiratory tract infection cases getting antibiotics. And we also have in anything between 30 and 50% of diarrhea cases getting antibiotics. And of course, most acute cases of diarrhea and upper respiratory tract infection don't need antibiotics. So we see a lot of misuse here. Next slide, please. So we have a lot of misuse, and why are antibiotics overused? So here are some staff views from Southeast Asia during the period 2010 to 15, and I've just included a few quotes here, and you can find this in the BMJ. A pharmacy technician in Timor-Leste: "We have a lot of soon to expire erythromycin, so we are pushing it to the dispensary and we will finish it in a few days." Issues of drug supply. A doctor in Sri Lanka: "According to SDG, standard treatment guidelines, for fever, coughs and colds, we should give paracetamol and or chlorpheniramine for a few days and only give antibiotics if there is no response. But I like to give the complete treatment, that is antibiotics, from the start." So here we have issues of belief in the guidelines. A medical officer in India: "We have to give antibiotics like azithromycin and cefixime because the patients have already been prescribed the simpler antibiotics by unqualified practitioners." And it's quite true that I saw unqualified practitioners using ceftriaxone in their clinics. Not even simple antibiotics. A doctor in Bangladesh: How can I make a proper diagnosis in 1 minute? A doctor having to see 200 patients in 4 to 5 hours. A peon, that is an untrained assistant in a sub-health post in Nepal. When Dr. Saab, that is a 2-year trained paramedic, is not here, I do dressings and give out cetamol. For young children, I give Cochrane, that is cotrimoxazole. So here we see issues of human resources and training impacting on antibiotic use in Bangladesh, workload, what's going on in the private sector in India, belief in guidelines, drug supply. So there are many health system reasons why we are misusing antibiotics. Next slide, please.
Section 3, madam. Intervention effectiveness.
Yeah, okay, go to the next slide. No, but nobody's doing these questions. I put them in faithfully according to your guidelines. No, nobody's interested to answer them. But anyway, here we are. What are the 2 commonest infections implemented to improve use of medicines and antibiotics in primary care in low middle income countries? And what is the average improvement in medicines use achieved with these 2 interventions? So anyway, if we go on to the next slide, we will see the answer to this. And this is from the WHO database, where we looked at intervention impact, and we looked at the median percentage change over all medicines use outcomes measured in each study for the period 1990 to 2009, where there was an average of 4 outcomes per study. Now, we only looked at interventions where they had evaluated using good study design, that is pre-post with control, randomized control trials or time series. So I put the intervention type on the left-hand side here and the number of studies that evaluated it. But the number of studies is not the number of times these interventions have been done. It's simply the number of times they've been evaluated properly. So actually, the commonest interventions that are used are printed materials and provider education. But printed materials have only been evaluated by randomized control trial 6 times, so we could find 6 studies. But provider education, we found a lot of studies, 29 studies. And you can see that the median impact of printed materials is 0, well, 1% here, and provider education 7%. So really quite no impact of printed materials alone, and provider education, a modest impact. But we see much bigger impact where we have provider and consumer education and supervision, 27% improvement, and community case management, 32% improvement from 10 studies. And community case management is where a member of the community is trained to treat specific cases of infection generally in the community. They are supervised, they are trained, and they're supplied with drugs. So next slide, please. And if we look at Cochrane Reviews of effective practice in health systems between the period 1999 to 2019, we find 36 of 185 reviews, mostly from high-income countries, on the impact of policies and interventions on rational use of medicines, RUM, and they show similar findings, including short duration of effect if interventions are not sustained. So next slide. Next slide, please.
Antimicrobial stewardship programs, most data.
Just go to the next slide. It's fine. Just go to it. Thank you. Yeah.
And move to the next.
So Yes, so this is a little bit more detailed data of antimicrobial stewardship programs. Okay, so the last slide showed you about interventions done in community, in low and middle income countries and high income countries. And here we look at antimicrobial stewardship programs, special reviews. The data is mostly from high income countries. Please stay on the next slide. And we find a Cochrane review of 221 studies on antibiotic prescribing for hospital inpatients showed that enabling and restrictive interventions were effective in reducing antibiotic use by more than 15% and by 2 days duration. And then if we look at, please stay on the slide, the next slide. It's gone back a slide. Can we go to the next slide?
Antimicrobial stewardship program most data. There's a slight lag, I think. To improve antibiotic prescribing for hospital inpatients, the Cochrane Review in 2017.
I'm not on the right slide on my slide. We should be on the next slide. Can you make it go to the next slide? Thank you.
It's already gone, ma'am. In the next slide.
Not on my screen, it's not up.
See. What's of the participants' answer?
In my screen, no
Now we
slides.
are on antimicrobial stewardship program. Now we're on the right slide. So, and the Cochrane Review of Hospital Inpatients Antibiotic Use Stewardship Program showed that you could improve antibiotic use, reduce antibiotic use by more than 15% and by 2 days duration without increasing mortality. Then a Cochrane Review in 2005 on ambulatory care use showed that intervention effectiveness is dependent on prescribing behavior and barriers to change in the particular community. So effectiveness is certain with interactive educational meetings, delayed prescription for antibiotics, and multifaceted interventions combining prescriber, public, and patient education. But it is uncertain with printed materials alone, audit and feedback alone, educational outreach, and physician reminders. And then the value of hospital antimicrobial stewardship from 146 studies showed the average cost savings of $732 per patient in the US, and a similar amount in the EU, mainly due to reduced length of stay. So there's 3 studies showing in more detail how stewardship programs can be effective. So next slide, please.
To encourage less antimicrobial.
Yeah, policies to, so this is question 4. This is the last question now. What proportion of countries globally have a government unit dedicated to monitoring use and promoting rational use of medicines and antibiotics? What are the 2 most important national policies you think countries should be implementing to reduce antibiotic misuse? Any callers for this? Has India got a specific government unit dedicated to monitoring use and promoting rational use of medicines and antibiotics? Okay, well, let's go on to the next slide. I don't think India has, last I heard. Anyway, so if we go to the next slide. So if we go to the next slide, please. Thank you. Now, here are national policies in place to promote rational use of medicines. And why am I talking about national policies? And that is because I've shown you evidence about the effectiveness of interventions or the non-effectiveness of them, but also a lot of countries are not implementing these interventions. They stop as soon as the money runs out. And so we really need to be thinking in terms of health systems and policies. And on the y-axis here, I've put in a set of policies that we looked at, and this comes from WHO surveys to ministries of health done in 2003, 7 and 11 on what policies are in place. And you can see that for most policies, 50%, only about 50% of countries said they were implementing them. That means 50% of countries said they weren't implementing them. And of those countries that said that they were implementing them, we have nothing, no information about how well they were implementing them. So we've got things here like, do you do regular drug use audit? Do you have a national strategy to contain antimicrobial resistance? Are antibiotics not available over the counter? Have you been educating your public? Do you have hospital DTCs, drug and therapeutic committees? Do you have a drug information centre for prescribers? Is there obligatory continuing medical education for doctors? Are your medical students trained on standard treatment guidelines? Have you updated those guidelines? And do you have a government unit for rational use of medicines, quality use of medicines? And we can see the question relates to the last point here. And we see that only half of countries said they had a government unit for promoting quality use of medicines. And it's not been improving between 2003 and 2011. Next slide, please. Now, I've shown you data on policy implementation and antibiotic use. Policy implementation came from the surveys by WHO to ministries of health, and the drug use information came from a database of published surveys from low and middle income countries. And we put this data together to look at those policies associated with lower antibiotic misuse in low and middle income countries. And this is published in PLOS One 2016. And if you look at the left-hand column, you can see the different policies. And then we have 4 indicators of antibiotic use in primary care. So the percentage of patients treated with antibiotics in primary care, the percentage of acute upper respiratory tract infection cases treated with antibiotics, the percentage of acute diarrhea cases treated with antibiotics, and the percentage of cases not needing antibiotics that got them. And if we look at the top 2 policies, having a national antimicrobial resistance strategy and a national Ministry of Health unit on promoting quality use of medicines, we can see that these policies were significantly associated with less use of antibiotics in upper respiratory tract infection and acute diarrhea infections treated with antibiotics. We can also see that most of these interventions, undergraduate training on guidelines, public education, updated formulary, dispensing drugs free at the point of care, disallowing prescriber income from medicine sales, disallowing antibiotics to be available over the counter, drug promoting, regulating your drug promotion, having hospital and drug and therapeutic committees, and having a drug information centre were generally associated with less antibiotic use if you had these policies than if you did not have these policies. And some of these were significant. Where there's a star, that's a significant association. And if we go to the next slide. Thank you. Here we are looking at, for those policies, we are looking at on the y-axis, the percentage of upper respiratory tract infection cases that got an antibiotic, and on the x-axis, the number of policies that a country was implementing. And each of these dots is a country. And we can see that the more policies you implement, of those ones that are associated with less use, the less use you have. And this is quite a significant difference. So you have countries like Congo, Nigeria, Mali, Senegal, implementing few policies, and where you have 80 to 100% of upper respiratory tract infection cases getting antibiotics. And then the other side, you have countries like Oman and Malaysia, Indonesia, where they were implementing more policies and had much lower use of antibiotics in upper respiratory tract infection. Now, so next slide, please. Thank you. So this global data suffers many limitations. It's good enough to see global trends, but the medicines use data came from often small non-generalizable surveys published in the literature. The policy data was reliant on questionnaires sent to governments by WHO, and some responses may not be accurate, and they don't reflect varying degrees of implementation. So the data is sufficient to show influence of policies on rational use of medicines, but not to benchmark country performance or inform individual countries for specific actions. So for informing countries what to do, you need to get local data for local action. And you need local data. So you need local data on use, policy implementation, and the health systems. And currently, there's no standard format for doing this, but we piloted one in Southeast Asia during 2010 to 15. And we undertook 20 two-week country visits to undertake a situation analysis of medicines management. And multidisciplinary government teams collected and analysed the data using a workbook tool, and they presented the findings immediately at a national workshop. And this resulted in recommendations for action and a report published online. And it required a mandate from member states through 2 regional committee resolutions. So next slide, please. And in India, we did this in 2 states, Rajasthan and Karnataka. So here's some photographs for some light relief. So getting started, here we are on the left-hand side, briefing a government team. And on the right-hand side, talking to the Department of Health Services, which is the department that coordinates a lot of the other departments that are responsible for different aspects of medicines management. Next slide, please. And here we are talking to stakeholders, a national regulatory authority, the Central Medical Supplies Depot, academia, professional bodies. And we need to talk to all these people because the regulatory authority is in charge of what quality of medicines and what can be sold over the counter. We need to talk to the Central Supplies Depot because they supply the public facilities. We need to talk to academia because they train medical students and pharmacists. And we need to talk to professional bodies because they are often responsible for standards. And here we see, I like this top right-hand picture because it shows a stakeholder pointing the finger at me. And this was my job in WHO. It was to mediate during these situation analyses when we visited countries for 2 weeks with government teams. It was to mediate between different stakeholders and to defend the government team from finding uncomfortable truths. And you may say, why did we do this in 2 weeks? Well, it was the maximum amount of time I could be spared from the office, and it was the maximum amount of time that governments could spare team members for the government team. Next slide, please. And here we are collecting data on medicines use. So an outpatient prescribing survey. done in the hospital outpatient dispensary or in a primary facility dispensary, a private pharmacy drug use survey. Here's the team lined up and all the shops behind us. Then drug use in inpatient wards, and then looking at drug availability in the stores. Next slide, please. And here we are looking at the national workshop and writing the report. So we prepared with the country teams. The team presented the findings at the national workshop. They had group work to develop recommendations, and then we wrote a report. And the report came out and was published online for partners to read once the Ministry of Health had approved it. And the next slide, please. So we then undertook a regional analysis of all the data that we found from these 20 situation analyses, 20 country visits. And if we look here, this looks at individual different types of policy in place on the x-axis, and then on the y-axis we have the percentage better or worse use with those policies. And we can see very similar findings to what we found with global data. So we can see that policies associated, and here you can also see the confidence intervals. So if it does not cross the red line, it means it's statistically significant. So we can see that policies associated with significantly better use, 5 to 10%, was not charging fees at the point of care in public facilities, undergraduate training on standard treatment guidelines, disallowing systemic antibiotics over the counter, a Ministry of Health unit dedicated to promoting quality use of medicines, public sector prescriber continuing medical education if it was done by Ministry of Health directly, but not if it was done by anybody else, monitoring your advertising for drugs, prescribing policies, disallowing drug revenue for public prescribers, that's selling of medicines in public facilities, having guidelines in your facility, having done public education in the last 2 years, and having hospital drug and therapeutic committees in your hospitals. Next slide, please. And you can find this in BMC Health Services research. And then if we look at those same policies, we see for the percentage of upper respiratory tract infection cases prescribed antibiotics, we can see that those countries implementing more policies had less use of antibiotics for acute upper respiratory tract infection. So in Southeast Asia, Bhutan came up top, Thailand a close second, and then others were implementing fewer policies and had much higher use. And this was highly significant. And really it was showing the same thing in Southeast Asia as we see for global data. Next slide, please. So what lessons did we learn from this? Well, irrational use is a multidisciplinary complex problem affected by multiple policies. And there are many stakeholders involved in supply, regulation, fiscal management, human resources, who impact on the use of antibiotics, as well as just people concerned with the prescribers, although that's very important. And we found that this new process with a workbook, and we used a workbook tool to during this 2-week visits to countries, it allowed collection and analysis of data by government staff on drug supply, selection, use, regulation and policy within 2 weeks. And it allowed us to feedback that information immediately to government, and involving government staff enabled them to learn about their own health systems in a holistic manner, identify actions for promoting quality use of medicines, build capacity, increase ownership, and it empowered them to implement change. And we found that snapshot data was enough to identify specific country issues and effective policies to promote quality use of medicines both within the country and in the region. And it was also, relatively speaking, quick and cheap, and it was liked by governments who actually do not want to have big surveys, which are costly and time consuming and may allow them to be benchmarked against their neighbours. So governments don't like that. They like this cheap and quick method. And we found that the same policies were effective in Southeast Asia as were effective using global data. And we also found that all governments and staff were fearful of the process initially, but we gained trust by using a strict non-blame approach, and it required facilitation, and it also required 2 resolutions, documentation of all findings, and constant follow-up. So it required a lot of work, but we did get quite quick results. Next slide, please. So just in concluding, we find that antimicrobial stewardship needs us to look at the health system and health policies, as well as specific interventions aimed at prescribers. And we can, if we understand our health system, we can organise a health system framework and a policy framework which actually encourages better use. And we also see that there are many similarities between containing COVID-19 and containing antimicrobial resistance. And I wonder if the COVID-19 pandemic may actually increase antimicrobial resistance because of increased use of antibiotics to treat respiratory infections and weakened health systems due to less resources being put into health systems due to the economic impact of lockdowns. So strengthening health systems with fewer resources requires using the essential medicines concept. That means having essential medicines lists and clinical guidelines, implementing essential medicines policy to ensure efficient supply and prudent use of medicines, but also of personal protective equipment, diagnostics, and so on. And we need strong public health approaches to infection control, proper use of PPE, testing and contact tracing and quarantining, safe water and hand hygiene, hand washing, social distancing, and vaccination, which I've left. And we need to monitor antimicrobial resistance, but we also need to monitor antibiotic availability, appropriate and inappropriate, antibiotic use, what prescribing incentives and disincentives there are. We need to monitor policy implementation, how many of us really know what policies we're implementing and how well we're implementing them. And we need to monitor infection control practices, vaccination and hygiene practices. So monitoring for COVID-19 also requires monitoring the same things: treatments and outcome, PPE availability, contact tracing, vaccination. So addressing the COVID-19 pandemic properly could result in benefits for containing AMR, but are governments willing to take the necessary steps for containing both these pandemics? I think that's the last slide, isn't it?
End of slideshow, madam.
Yeah, well done for managing the slides. Quite tricky.
Thank you.
So any questions? Maybe we'll get more questions than we had from polling.
Okay. Ma'am, I'll start the questions. One is actually this management of medications has become a major area in all the accreditation tools for hospital accreditation and these things. So a lot of guidelines have come and standard treatment protocols have been evolved for management of medications. Have all these things made any difference in the scenario, both in the regional level as well as in the Southeast Asia and global levels? The awareness about accreditation programs and management of medications.
Well, I don't know if they've made a difference in Southeast Asia. I know that if you implement the policies I showed you, they are associated with better use. But what is included in the accreditation program, I don't know. Quite often, the accreditation programs don't include this detail of, you know, they might say, have you got a drug and therapeutics committee? But they don't include what has your drug and therapeutic committee actually been doing. You know, with regard to drug supply, I don't know how many accreditation programs really include, are people sticking with the formulary? You know, is this formulary consistent with the state or national essential medicines list? How many people are going outside to buy their medicines? How, you know, have we got drug utilization review programs? You know, what are they covering? So in many of the accreditation programs I've seen, we haven't seen that detail. We might have got as far as, do you have a drug utilization review program? Do you have drug and therapeutic committees? But we don't actually see a review of what these hospitals are doing. Nevertheless, we do know that in a general way, those countries that say they have drug and therapeutic committees. And when we went to Southeast Asia, we looked to see, we judged on whether a country said they had drug and therapeutic committees by actually going to hospitals and seeing whether they had one there or not. It is associated with better use than where we found nothing going on. But I'm sure we could do much better. But even in the UK, and I have to give a talk next week on this subject, and you know, it's students, and I looked at the UK National Action Programme for Containing Antimicrobial Resistance, and there they have the Quality Care Commission, and they are looking at you know, drug and therapeutic committees and various actions in hospitals, and even there they said that a number of hospitals did not really have sufficient, in their mind, actions going on to contain antimicrobial resistance. So I think action depends on how much you're really looking at what hospitals are doing and what kind of infrastructure you have in government to do this. That's why I think it's very important for governments to have a unit in the Ministry of Health dedicated to promoting quality use of medicines, because if you don't look at what hospitals are doing, and then, you know, they may be doing anything. But I mean, we're getting there slowly, but we've got a long way to go, I think. Did that answer?
Yeah.
A little bit.
There's one more question I have. The other one is, see, we are talking a lot about how we are using antibiotics in the community, how we are using antibiotics in the hospital, and how this is perpetuating infections. But I think there's one area which kind of goes underneath is the use of antibiotics in the animal husbandry for veterinary practice, the use in poultry farms for tetracycline. I think they are using quite a bit in chicken so that it comes out better. So what kind of policy decisions are there? Because those are things which don't come to surface, but still it perpetuates a lot of resistance. So has any initiative been taken to address the abuse in veterinary practice?
Well, veterinary practice is way behind human practice. So in that respect, I mean, and it's very difficult to influence veterinary practice when our human practice is not marvelous. You know, it's very difficult to influence community practices when our hospital practices are not marvelous, because, you know, community people copy hospital people. And, you know, even unqualified quacks are copying the GPs who are copying the consultants. So that the whole thing goes down the line. And if we can buy anything over the counter for humans, then farmers are going to argue, why can't they buy anything over the counter for animals? But there have been some initiatives. So in the European Union, they have banned growth promoters. And growth promoters are small dose antibiotics which are given to animals in their feed, not because the animals are ill, but because they put on meat faster. So that has been banned, and I think it has had some impact. And there are various initiatives going on, but we've got a long way to go on that. And you know, yes, everybody who's eating chicken in India is also consuming some antibiotics, not only chickens, in vegetables and fish and fruit. They're spraying stuff. So we've got to stop it. Otherwise, we're going to end up in a pre-antibiotic scenario. Yeah. So there's a lot of things to do. And actually, just looking at the health system issues for human use, we can see there's a lot of things in our health system impact on how we use medicines, and we can deal with these things. We know what to do. It's just a question of doing it. We've now got some evidence. 20 years ago, we didn't have evidence, but now we really do know that certain policies are associated with less misuse. And really, we cannot blame prescribers for overusing antibiotics if we are not training them in guidelines, if we are not controlling the drug supply, if we are not monitoring and supervising. And all these lessons could be translated to the veterinary sector as well.
Yeah, I have a question, Dr. Catherine. Yeah. First of all, your comparison of antimicrobial resistance with COVID pandemic was an excellent first slide. I must compliment you. It showed us, we never realized the seriousness of that. It's rather more serious than the COVID pandemic. That was quite impressive. But the question is, even though we are here free, I said happy, and we never know, uncertainty is all there. And in many countries, the COVID, the second wave or third wave, whatever that has been coming. Now, what clear message you like to give to the COVID patients? Even in India, in Mumbai, some 40 people died yesterday. That kind of things are there. What clear message you like to give when you diagnose a patient with a COVID, whether to give a prophylactic antibiotic or not? Because we are confused. The chloroquine controversy, then azithromycin controversy, by heads of the state prescribing so many things. Today only Ramdev Baba has put forth a COVID immunity booster kit in the market for 545 rupees. So it leads, forget about we medical people, it will, even common person will be very much confused.
Well, in the UK, antibiotics are not in any guideline for COVID. And there has been a study that showed that antibiotics don't do any good for COVID. That, and that the argument has been that you have a lot of secondary infection, like you have for flu, you would have secondary bacterial infection causing pneumonia in COVID. But the evidence so far is that you don't get a lot of secondary bacterial infection in COVID patients. So the guidelines are not there. Of course, once you get somebody seriously ill in ICU, they may have all sorts of secondary infections going on, but the majority of patients don't get to ICU and they don't need antibiotics. But we do see, I've heard that a number of countries now have antibiotics written into their guidelines for uncomplicated COVID. And so, that's all I can tell you, is that we shouldn't be using it for uncomplicated people. I mean, people who are not on ventilators, who just have simple COVID, don't need antibiotics.
Yeah,
that's
even WHO has said for minor cases of COVID, you don't need to start a kind of a prophylactic antibiotics.
Yes, you shouldn't use prophylactic antibiotics.
I'd like to ask Dr. Geetanjali if she wants to ask any question, because Madam has raised her hand.
Thank you. It was a pleasure listening to Kathy after such a long time, and I am seeing her after such a long time. We actually plan to have a chat after this on a one-to-one basis. Kathy, thank you for this wonderful presentation. I enjoyed it. I just want to add to that question which Maha asked you about. If since many hospitals are going in for accreditation, do you think the antimicrobial use will be a little better? See, one thing, Maha, there is a big difference between the government and private hospitals. In the private hospitals, it is still easier to control certain things and, insist that people use them. In the government hospitals, it becomes, very difficult. And even though I'm sitting here in AIMS Bhubaneswar, I can tell you that many departments, big departments, like for example, orthopedics, general surgery, or take anything, I mean, cardiovascular surgery or any of the things, most of the time they do, it is what the head of the department or, whoever is heading the department is fancy. Whatever takes his fancy, they do. We tried now with a little bit of success, at least trying to regulate, prophylaxis, surgical prophylaxis, trying to limit it to, just one dose, and if at all, not more than 24 hours kind of a thing. So what I feel is the way to get some success is not to try too many things, but at least small bites. The low hanging fruits, if we can try, then slowly we get a culture of people trying to say how we can use it better. We do have operating procedures. We have a antimicrobial stewardship program going on here, but I'm not sure how successful we are. But at the same time, one of the good things which has come is we are having a lot of information about this. So it's previously people hardly used to speak about antibiotic resistance. Now at least everyone is aware that there will come a time when we are just waiting to go back to pre-antibiotic era kind of a thing. So they know that this is there. We have a long way to go, but that might be the kind of silver lining which we are looking at. Thank you.
Thank you, ma'am. Thank you for that comment. But sir, you want to ask any questions?
Yeah, it was a wonderful talk. Only thing I want to know from your experience, in developing country like India, the antibiotics are available over the counter, so people can just go buy without even prescription. This is one of the major reasons for misuse of antibiotics. They take 1 or 2 doses, then they, as you rightly said, upper respiratory tract infection, little sore throat. They will buy antibiotic, take for 1 day, then he becomes better. He would have become better otherwise. Then they stop. So I think there is a lot of misuse of antibiotics because of the easily available over the counter. Whereas in most of the developed countries, you cannot buy antibiotics without prescription. Of course, some restriction may come on that. Do you feel that?
Yeah, I think over-the-counter availability of antibiotics is really a really big problem. And when I was in WHO, we were always talking about this. And there was always the argument that if you stopped having antibiotics available over the counter, in some poor countries, people wouldn't have access to antibiotics. But we've been advocating for a long time, you start with even if you can't get rid of all antibiotics over the counter everywhere to start with, you can start with not having second, third generation antibiotics available over the counter. So in India, I saw an unqualified practitioner giving ceftriaxone injections. I had the privilege of talking with some unqualified practitioners set up for me by the regulatory authority. And I remember one gentleman, I went to see him, and he had a pile of prescriptions on his desk, little bits of paper. And I looked and there was ceftriaxone there. And sometimes there were several injections there. And I said, well, this is a bit difficult. You know, if you have several injections, you have to give, it must be painful for the patient. Oh, no, he said, it's not painful. I put them all in the same syringe. I made an improvement on what I'd seen in my apprenticeship to some private practitioner's clinic. You know, so what I said was, I don't think this is a good idea to put this into the same syringe. And he had already got the message that you don't do it for children. So, you know, you have to make your message slowly. But yes, we shouldn't be having ceftriaxone over the counter, nor meropenem, nor any of these other things over the counter. Yes, you may need amoxicillin over the counter, or in some places where there's no health facilities for local people, or, you know, but you know, I think the COVID pandemic has shown one thing for us all, and that is, if there's a will, there's a way. They produced a vaccination with a lot of work in 1 year. They've done a lot of things because suddenly it became important to people to do it, and they could do it. So why can't we set up basic policies and just do it? You know, there is no country in the world that has narcotics available over the counter. So why can we not ban ceftriaxone, meropenem, and all these other things from over the counter? And if you're caught doing it, you lose your license. There might, you know, if there's a will, there's a way. The problem is there isn't a will. That's the last statement on my slide. Why isn't there a will? Because there's vested interests of, you know, Drug and Chemists Association, pharmaceutical industry, who are, you know, busy selling stuff to these people. And that's why I think we really need to understand our health systems and the incentives and disincentives that are going on, because quite often all our effort is directed to some prescriber and saying, don't use so many antibiotics. Well, we are not looking at the whole system, and very difficult for private prescriber to resist giving antibiotics if the patient can just buy it next door. So we need to really be having a stepwise approach to stop some of these antibiotics being used. And that would be, you know.
Yeah. Thank you, Dr. Kathleen, for taking that question and answering very nicely. If I were to summarize the entire thing, one is what you said, no? When there is a will, there is a way, and be the change you want to see. Yes, sir?
Catherine, I wanted to say something. You know, I was muted and I didn't see that. See, now the irony is government is giving free vaccination everywhere, but people are not taking. It is quite shocking. See, we are talking of so much, you know, in India, government is giving free vaccines. The percentage of even health science professionals is hardly 10%. In my own institute, I'll say, this is where there is a will, there is a way. You know, that's what we have been telling. Under the circumstances, what I say is, you will see in the next couple of days, everybody here in India will be taking that immunity booster set by Ramdev Baba. You know, nothing, no prescription, nothing across, no innocuous. This is what is going to happen.
Well, I think, you know, when we have a vaccination program, it's not just a question of giving the vaccination. You have to have the public information system, and it has to be wide-reaching. In the UK, every advert includes something from government about having your vaccination. Anyway, so that's it.
Yeah. There was some disturbance I have noted, madam.
It was just, I think
Okay.
what I was saying was just that when you have a vaccination program, you have to set up the people who are given the vaccination, but you have to have public information and really big public information program, as well as the logistics, the supply, the vaccinators, and so on. It's like all these things, you really need a comprehensive approach. that answered it a bit. They've got now a 80% coverage, 80 to 90% coverage in Britain for those people who've been offered the vaccine. But you see, you've got other problems like social media and disinformation on social media, and all these things have to be counteracted.
This is what has emerged as post-truth, no matter. The social medias have taken over most of the things. Dean sir, are you trying to talk? Your mic is muted. Are you trying to speak?
I think he's speaking to somebody else.
Yeah, it looks like that.
Yeah.
If I were to summarize this entire talk, two things came. One is that when there is a will, there is a way. And be the change you want to see. That if you want the hospital infections to come down and you want the community to come down, then we need to start from top and go down. That is what is another message. And one more very nice thing what Dr. Gitanjali said, start with small steps and then take the big ones so that it will make a difference. I still remember that Madam used to do that session on there's no free lunch. She used to say how to resist the drug reps. So that is a very famous session she will do for the medical students, both UGs and PGs. So that is what we have in this thing. Okay, sir is gesticulating and talking, but I'm not sure. Our dean.
So another thing, perhaps I can just summarize by the experience in Southeast Asia. We were able to work with government teams to look at health systems in a holistic way within 2 weeks and find out what were basic, really serious problems and what policies needed to be put in place. And actually, if you look at the literature and you look at WHO's information, there's very little information on what policies are actually being implemented. But we could really start. But, you know, do you have guidelines in your health facility? You know, are people using the same guidelines in the medical schools? All these things, you know, are important. Do we have a unit that's dedicated to looking at how antibiotics are used in government? What are they doing? Are they actually looking at what, you know, hospitals are doing in communities? Because if you don't have these things and you don't have information on use and policies, you cannot really start to address your health system. And you don't need years of work to find out that information. You can do it in 2 weeks.
And with a logbook.
Yeah.
Along with a logbook.
Yeah.
Okay.
You can do it
Thank
quickly.
you very much for that. Yeah, thank you very much for that wonderful session, madam. It was extremely interactive and it was very nice of you to share your experiences, both the hard data as well as the soft data. So we'll remember the quack who was prescribing ceftriaxone for a long time to come. So I think that is what stories do to us, that they make us remember things. So taking things a little far, like how the change starts with us, like as Mohandas Karamchand Gandhi said, be the change we want to see. So there is one Chennai declaration for antimicrobial resistance. The private hospitals in Chennai came together and they have formed a declaration for antimicrobial resistance prevention and also safe use of antibiotics. So Dr. He is talking about what this Chennai declaration is all about and what strategies they have done at once to try microbial resistance across multiple colleges, multiple private hospitals. So that would be the next week's episode. So next Friday, that is on February 26th, we would be having a talk by Dr. Abdul Ghafoor. He's an infectious disease consultant. He's attached to the Apollo Hospitals, Chennai. And he is the author of this Chennai Declaration. And there is a very nice interview about this whole thing in the BMJ. So if you just search for Abdul Ghafoor and Chennai Declaration, you would get his interview. So you could see that also. So he will talk to us about strategies to combat antimicrobial resistance at local level. So what they have put in. So please stay tuned and come and attend the next session. this the video recording of this particular Dr. Kathleen's session will be available in our YouTube channel, AVMC FFF YouTube channel. We'll also share this with participants, and I hope Dr. Kathy will allow us to share her slides also with the participants. Can I, madam?
Yeah.
Okay. Yeah, thank you very much. So with this note, we will wind up today's session. And as we were all discussing, please take the vaccines. They seem to be safe, and please stay safe till we meet you again next Friday. Bye-bye. Thank you very much. Good day, ma'am.
Okay.
Thank you for
Bye.
the
Thank
nice.
you.
Bye-bye. Bye-bye.
Bye.
Thank you.
Bye.